afternoon, everyone. Apologies, we're just working through a few technical issues. We will be getting started in just a moment. In the meantime, if you have not done so already, go ahead and feel free to introduce yourself in the chat. Just be sure to select everyone when you are using that chat function. All right, I guess we will go ahead and get started. Again, good afternoon, everyone. My name is Chelsea Ader. I'm one of the social workers on the BHIPP team. Just to give a quick background on who we are, if you are not familiar with us yet, we are Maryland BHIPs, so Behavioral Health Integration in Pediatric Primary Care. So we offer free support to pediatric primary care providers throughout the state through a various number of ways. We do that through training and education. We offer a consultation warm line. We offer resource and referral support. Another arm of our program is our regionally specific social work co-location. And then more recently, we have started a Project Echo and offering direct telemental health services, including care coordination. Just a quick note about our partners and funding. So I will go ahead and take the time to introduce our presenter for today, Dr. Tiffany Beeson. Thank you so much for joining us. So Dr. Beeson is a licensed clinical and community psychologist at the National Center for School Mental Health, and she's also an assistant professor in the Division of Child and Adolescent Psychiatry here at the University of Maryland School of Medicine. So just a little background, Dr. Beeson has served as a school mental health clinician in the Baltimore City public school system for several years, where she provided supports that promote positive mental health for all, as well as early intervention and treatment services for youth experiencing mental health conditions. Dr. Beeson also serves as the director of cultural responsiveness in the National Center for Safe Support Schools. Dr. Beeson is also a co-developer of a national curriculum for educators to promote culturally responsible and equitable mental health support in classrooms. So again, thank you so much, Dr. Beeson, for presenting for us today, and I will go ahead and pass it over to you.
Thank you so much, Chelsea, and good morning, afternoon for folks who are joining us. And if you could go to the next slide. So thank you again for joining us, and I am very excited to be here today to talk about culturally responsive, trauma-informed practices for pediatric primary care providers and behavioral health providers. And before I get into the content for the talk today, I wanted to take a moment to engage you all in a brief connector activity. And I am asking that for folks to share their responses to the question on the slide. What is one of your favorite spring self-care well-being activities? So please feel free to share your responses in the chat box. And just so the audience is aware, I cannot monitor the chat box while I am presenting. So Chelsea, if you could help me with shouting out some of the, or Rebecca.
Sure, I see.
We're getting
Cleaning, hiking, walking, going for walks, walking outside, soaking up some sunshine.
Awesome.
Lots of outdoor activities for sure. Jogging, enjoying the blooms on the trees in the neighborhood.
Awesome. Thank you. Thank you all for sharing about your self-care and well-being activities. It's so important that we engage in activities that support our own well-being, especially as providers, and who pour so much into the young people and the families that we serve. And so thank you for participating in this exercise, sharing with your peers about what you do to be well. Next slide. So today I will be speaking specifically to culturally responsive and equity practices that are trauma-informed and promote positive mental health and well-being for young people and families, including those from marginalized communities. And in doing so, you can see the learning objectives here. I will be defining some key concepts, describing several strategies related to that are culturally responsive and trauma informed, as well as sharing some resources that you can use to apply these strategies in your clinical practice. So I think it's safe to say that we all can agree that all children, and people for that matter, should be safe and supported. But in reality, they often are not. Within our social systems, including those that are child-serving systems, like our mental health care system, our schools, there are various forms of social oppression, including ableism, classism, heterosexism, just to name a few. And these forms of oppression cause inequities that act as social determinants or influencers of health, which by definition affect the growth, development, and the well-being of young people and families. Social inequities can cause significant distress and are often experienced as traumatic to both individuals and communities. Fortunately, the culturally responsive practices that I will be describing today can be used to foster child and family positive mental health and well-being in our child-serving systems, including schools and our mental health care system. Next slide. So today I'll be discussing cultural responsiveness, as I mentioned, but using the cultural responsiveness, anti-racism, and equity, or CARE, framework of the National Center for Safe Supportive Schools that's focused on fostering safe and supportive schools through trauma-informed and culturally responsive comprehensive mental health. And before I get into the content, I will break down the 3 parts of this CARE model. The first is culturally responsive care, which is about intentionally honoring and integrating the child and family's cultural and identity-based values, beliefs, strengths, needs, and expectations into healthcare services. What this can look like is seeking to understand youth and family health beliefs, and expectations of care, understanding and addressing linguistic challenges, as well as honoring culturally based family dynamics that impact health decision-making processes. Anti-racism in child-serving systems involves intentionally promoting policies and practices that oppose racism. And being anti-racist is more meaningful than claiming to be not racist, which does not involve any action. Anti-racism, on the other hand, is all about action, or actively doing the work to promote racial equity. Finally, equity refers to ensuring that every child and family has what they need in order to thrive and be well. And that's the framework I will be working from today. Next slide. So you may be asking, why is cultural responsiveness or CARE, as I laid out that framework, important to pediatric and behavioral health providers? Well, for several reasons, and I'll just name a couple. Research has shown that cultural sensitivity and responsiveness in healthcare positively influences patient adherence to treatment, as well as health and mental health outcomes. Research has also shown that low adherence to recommended treatment behaviors among patients from some cultural groups, including Black, Indigenous, and people of color, is in part attributed to lower cultural responsiveness of providers. Practices that are not culturally responsive or not anti-racist or equitable do contribute to health and mental health disparities, and these disparities are harmful to individuals and communities from historically marginalized groups. And as I mentioned earlier, inequities can and do cause significant distress and can even be experienced as traumatic to individuals and communities. Conversely, practices that are culturally responsive, anti-racist, and equitable are more trauma informed and support us as providers in promoting positive mental health and well-being for the youth and families we work with. So as I mentioned today, I'm going to be speaking to specific strategies that providers can implement in their clinical practice that is aligned with cultural responsiveness and trauma-informed care. And before I get into those specific strategies, I wanted to talk with you all about cultural humility, which I regard as a bit of a prerequisite of being able to promote cultural responsiveness or care in our work. Cultural humility is defined as the ability to maintain an interpersonal stance that is other-oriented or open to the other in relation to aspects of cultural identity. Those who value cultural humility seek to learn about diverse cultures. However, rather than concentrating solely on gaining knowledge about different cultures, cultural humility asks that we are open and humble when engaging with individuals from cultural backgrounds that are different from our own. And in this definition, I intentionally avoid the language cultural competence, because this language sometimes unintentionally implies that this process of demonstrating cultural humility has an endpoint, when this is simply not the case. Rather, cultural humility is a lifelong commitment to self-evaluation and critique, to learning about diverse cultures, and working intentionally with others to limit power imbalances and dismantle systems of injustice. And I'll be engaging you in some very brief reflection exercises in a moment to illustrate what it looks like as a provider to foster cultural humility. Part of being culturally humble is understanding and managing our implicit biases. There are two key elements of an implicit bias. The first is that it involves perceptions of other people, and second, a lack of conscious awareness. Implicit biases are often aligned with negative societal messages or stereotypes about groups. Implicit biases are pervasive, meaning that everyone possesses them, including providers who value equity. And our biases tend to favor our own group, but we can have implicit biases against our in-group. An example of this is internalized racism that I will discuss a little bit more later. The good news is that we can manage our implicit biases by engaging in critical self-reflection to understand our own worldviews, biases, and their impacts on our thinking, behaviors, and relationships with others, including our patients. Now that we have a shared understanding about what biases are, I would like you to, or I'd like to invite you to respond to this reflection question in the chat box. What is one biased perception or stereotype that other people may have about youth and families who you work with? And related to that, what is an impact of this bias on youth and families? You can feel free to either reflect privately or in the chat box.
Would you like me to read the responses that are coming through?
Sure, you can read a couple. Thank you.
So we have crime, theft, and drugs. They are lazy. The patient feels misunderstood. Misunderstood is coming up again, yeah. Income level is correlated with intelligence. Lazy criminals.
Thank you. Thank you for sharing your reflections. And I know that for some, this could be difficult to think about and to reflect. And the reason I engage the audience in this reflection activity is that normalizing, my intention was to normalize the process of acknowledging biases. And this is important because whether we name biases or not, they exist and they do impact the youth and families we serve. They impact us as individual providers, and unpacking them can help us begin to manage, challenge, and address them. So thank you all for sharing. Next slide. As clinicians, we have an ethical duty to, at minimum, do no harm. However, we each possess implicit biases, and it is important that we do the work, the individual work, or the work to manage and address our implicit biases in order to ensure that they do not have a negative impact on our service to our clients and patients. So on the left, you see some strategies for clinicians to support them in managing and addressing implicit biases. This includes individual reflection, clinical supervision, peer consultation, independent study, and continuing education. And this all can be helpful to ensuring that we are fostering cultural responsiveness, anti-racism, and equity in our work. On the right, you see the link to the Harvard Implicit Association Task, which is a resource for individuals to use that can be helpful in helping them understand their own personal biases, which can in turn, that information can in turn be used to help individuals support or promote addressing their implicit biases. And the link to the resources that I shared today will be shared after the session, including that one. So as I mentioned earlier, a key part of being culturally humble is engaging in intentional reflection about our own biases and our own identities. Dr. Pamela Hayes developed an addressing model that helps us recognize 10 common factors of cultural difference, including age and generational influences, developmental and acquired disabilities, religion and spiritual identity, ethnicity and racism, or ethnicity and racial identity, socioeconomic status, sexual orientation, indigenous heritage, national origin, and gender identity. And this addressing tool can be helpful in walking us through various domains of our own identities to increase our self-awareness. Engaging in self-awareness calls for us to consider how our identities that I just named, or different aspects of our identities, relate to power and privilege, which are defined here. Power is defined as the ability to influence and make decisions that impact others. Privilege refers to advantages and benefits that individuals receive because of social groups they are or are perceived to be a part of. Privilege is often a result of marginalization of another group. So now I'm going to turn back to the addressing model that you saw just a moment ago so that we can understand how power and privilege relate to identity. So let's take a look at this table, which reflects our thinking about how identity relates to power and privilege. The first column lists the identity characteristics you just saw a moment ago in the addressing model. The second column names the specific groups within that domain that benefit from more power. Finally, the third column lists groups that experience less power or privilege or oppression within the characteristic domain. It is important to be aware of our power and privilege that we possess as individuals, and also to know that certain identities necessarily carry weight and power while others carry less power. Next slide. Oh, sorry, you can go back. So now more on this addressing model. Now I will be inviting you to take a moment to reflect privately to yourself. How do your personal characteristics relate to more power and privilege? as well as less power and privilege. And I will pause for a moment to allow for individual reflection. How do your personal characteristics relate to more power and privilege? And how do your personal characteristics relate to less power and privilege? Thank you for taking that moment to pause and reflect. Understanding our relative power and privilege in certain settings helps us to be more aware of ourselves and our relationships to power, privilege, and oppression. And this awareness can help us lean into empathy about the experiences of the young people and families that we serve. So I encourage you all to continue to do this type of reflection in your process of fostering cultural humility and awareness. Next slide. Now that we understand what biases are and how they can show up in our actions and behaviors, and we've talked about power, privilege, and oppression as it relates to our identities, I like to invite you to reflect on this question on the screen in the chat box, or you can do so privately if you choose. What issues related to power, oppression, and identity impact the youth and families you work with? How do you see power and oppression showing up in the work of the young people and families that you serve?
Seeing transportation access, access to care, demographics, self-esteem, ability, bravery to advocate or not, undocumented children, unstable housing, food insecurity, youth not listened to.
Great.
Lots
Thank
of
you all.
resources.
Thank you all for sharing your reflections. Keep them coming. So just a moment ago, you privately reflected on your personal identity and relation to power and privilege and oppression. And you may be wondering why I invited you to reflect. The reason is that reflecting on our identities, worldviews, and biases can reveal areas where we are actively engaging in practices that are aligned with cultural responsiveness and where we can be making some improvements. So again, I encourage you to continue to use reflection as a strategy to foster cultural humility and awareness. And related to this, I have included on the screen some simple questions that can help individuals begin or continue in their process of self-reflection. And these could be reflected on individually or in supervision or with peers or however it feels helpful to you. The first is, what social or cultural groups do I identify with? What are the identities of the young people and families I work with and the histories of these groups? How might my beliefs, values, and biases impact my style of relating to children and families from various backgrounds and identities? How do they relate to the interventions I use in treatment, the questions I ask, the assumptions I make, etc.? All right. So we've talked about the prerequisite work to foster cultural humility and self-awareness in order to effectively engage in culturally responsive supports. Now I want to move on to talk about more specific care or culturally responsive anti-racist and equitable strategies for clinicians. A first strategy that is really understanding racism as a multi-layered construct. Dr. Camera Jones has a 3-level framework of racism, and I will walk you through this model in this slide. Dr. Jones defines institutionalized racism as differential access to the goods, services, and opportunities of society by race. Personally mediated racism is, in complex terms, the differential assumptions about the abilities, motives, and intentions of others by race, and the differential actions based on those assumptions. But in simpler terms, I just describe personally mediated racism as prejudice and discrimination, or acts that happen person to person, so to speak. And then finally, Dr. Jones describes internalized racism as Black, Indigenous, and people of color accepting negative societal messages about their own abilities and intrinsic worth. And of note, I wanted to make clear that other forms of oppression, like sexism, for instance, shows up at similar levels. And it's important as clinicians that we have an understanding of how oppression shows up for individuals and communities. Racism and other forms of oppression are social determinants of health, and we have a role as providers to understand how oppression works and impacts the patients we serve, and actively engage in culturally responsive, anti-racist, and equitable practices. And if you are interested in learning more about this framework, I invite you to check out Dr. Jones's TED Talk. And I think that we can provide a link to the TED Talk in the chat box. And if not, it will be included in the resources at the close of this presentation. Next slide. So the next strategy aligned with culturally responsive and trauma-informed care is broadening our understanding of trauma to incorporate historical trauma and trauma caused by racism, as well as other forms of oppression. Within mental health care, trauma is often conceptualized as an event that involved the actual or possible threat of death, violence, or serious injury. However, traumatization does not just occur from the experience of a discrete incident or incidents. In the case of social injustice, people from communities that are marginalized experience a whole society, systems that have historically resulted in multiple inequities, multiple forms of dehumanization and injustices that are traumatizing. So it is important to incorporate historical trauma into our definition of trauma. Historical trauma is loosely defined by the cumulative harm to a group caused by an historic event, such as genocide, violent colonization, or slavery, and the related ongoing oppression. For example, racist events or racial traumas, or traumatization due to the experiences of racism, such as negative messages in the media about people of color, racial profiling, and race-based discrimination. And I make this argument about broadening the definition of trauma because how we define trauma influences the focus of our interventions. And our interventions should address trauma in this broader sense, but sometimes they do not. So in the vein of really broadening the definition of trauma, the next step to doing this work is to utilize trauma or ACEs, or adverse childhood experiences assessment. All pediatric primary care providers and behavioral health providers should screen for trauma. and in doing so, utilize best practices for engaging in trauma-informed screening and assessment. And the goal, in short, is to be sensitive in the process and to use a process that is developmentally appropriate. The National Child Traumatic Stress Network has a resource with practical tips to foster trauma-informed assessment and screening, including discussing what a youth and family needs to feel safe in the process of talking about trauma, clarifying the purpose of why we are asking about trauma in the first place, monitoring how the child and family is doing during the process by simply asking, how are you feeling during this part of our assessment or our interview? And taking the time to explain how the information about trauma exposure or symptoms will be used, as well as doing appropriate follow-ups on questions related to safety. This is very important because some trauma assessments will ask about suicidal ideation, for instance, and it's so important that we're not just giving folks questionnaires and not doing appropriate follow-up to screen for safety. And then finally, making appropriate referrals to a behavioral health provider when applicable. All right, so related to screening for trauma or adverse childhood experiences, there are several, and also related to social injustices, there are several screening tools that can be used to gather information about child and family exposures to and the impact of social injustices on children's emotions and behaviors, including those that are listed here on the screen to the right. So there's a trauma symptoms of discrimination scale, perceptions of racism in children and youth, and the expanded ACEs questionnaire. So many of you may be familiar with the ACEs survey or ACEs studies. And the survey essentially assesses for 10 adverse childhood experiences that range from having a parent with a mental illness to witnessing domestic violence. And these adverse childhood experiences are important for us to assess for because they are linked with adult health and well-being outcomes. The expanded ACEs survey included the 5 additional adverse childhood experiences that you see here on the left. So witnessing violence, feeling discriminated against, adverse exposure to adverse neighborhood experiences, being bullied in school, and living in foster care. So it was important that these ACEs were added to the questionnaire because these are experiences that are experienced as adverse, and are actually quite common among children from marginalized backgrounds. And this expanded ACEs survey can be used in the screening process to understand child and family exposure and thereby risk level, and thereby used to work with families to connect them with necessary resources and supports. And again, the links to these resources will be included in the follow-up from this talk. So we know that ACEs are actually quite common and that they are connected to the development of later health and mental health problems or conditions. But fortunately, we also know that positive childhood experiences can actually mitigate the impact of adverse childhood experiences. And items from the Positive Childhood Experiences questionnaire are listed above. And the factors that are shown to have mitigating impacts on ACEs exposure and then later development of health outcomes or challenges are feeling able to talk to your family about feelings, feeling your family stood by you during difficult times, enjoying participation in community traditions, feeling a sense of belonging in high school, feeling supported by friends, having at least 2 non-parent adults who took genuine interest in you, and feeling safe and protected by an adult in your home. And it's so important in the process of screening for trauma that we also screen for these important factors as well. Assessing for protective factors is a trauma-informed practice that aligns very nicely with cultural responsiveness because it is a strengths-based approach that considers individual and family resilience, which is a helpful way to engage all patients, and especially those from marginalized communities that often are overly pathologized or problematized. Next slide. So I mentioned a strengths-based approach, and that is the next strategy for fostering cultural responsiveness. And I wanted to talk a little bit more about the key parts of a strengths-based approach. The first way to kind of utilize a strengths-based approach is to lead with what the child and family's strengths, skills, or assets are. So it really involves kind of moving away from this deficits-based approach that begs the question, what's wrong with you? And moving more towards a strengths-based approach that begs the question, what is right with you? And providers should know that within many cultures, there is a stigma associated with mental health difficulties. And in our process of working with families, they may feel defensive if they believe their child is being labeled by their problems and not appreciated for their strengths. So this strengths-based approach can reduce stigma, as well as families' fears of their child being negatively labeled. So like I said, it involves asking youth and families about what's right with them, leading with what the child does well, presenting challenges for areas of growth, describing mental health services as additional supports to help the child or family meet their goals, and then being intentional on promoting positive views of self, healthy relationships, and adaptive skill sets through services. Next slide. All right. The next strategy is to promote cultural-based strengths, or skills and strategies that youth and families use to thrive and be well in the face of racism and other forms of oppression. Many families of color prepare their children for racism and other forms of oppression by teaching young people about these issues, as well as various ways to resist injustices in order to thrive. Some of the more common strategies include seeking out safe spaces and support from group members or allies, demonstrating group pride through participating in cultural celebrations, acknowledging and celebrating community-based strengths, displaying symbols of cultural or identity-based pride, as well as using advocacy skills to speak out against injustices. In the work that we do in various child-serving systems, we can help support young people with fostering these skills by making space in our individual sessions or family or group therapy, as well as trainings for providers where we teach folks about students' cultural-based strengths or young people's cultural-based strengths and support them with supporting young people in using these skills at home and school. So to break this down a bit further, I'd like to provide some examples about what this could look like in your practice. So if you are a school-based clinician, where I've done most of my clinical work, this could look like hosting safe spaces or groups or organizations that are focused on students from the well-being of students from marginalized populations, or posting LGBTQ+ pride symbols in your office, posting images or posters that reflect diverse cultures and role models or exemplars from communities of color, and teaching young people about how to use assertiveness communication skills to speak out against unfair rules or consequences. Next slide. By the way, there's a little bit of shuffling happening.
Oh, sorry. Thank you.
All right, now that we understand All right, so sorry about that. Now that we understand, or we've talked about some cultural-based strengths, I'd like for folks to respond in the chat box with this reflection question. What strategies or practices do you use to promote youth and family cultural-based strengths? Rebecca, I'm not sure if there are comments in the chat box or not.
We haven't seen any yet. I think we're still reflecting.
There's actually a couple that, what would we be able to do for someone with a rescue squad and EMT? Ask about pronouns, give my pronouns. Having a translator present or providing Spanish educational materials, motivational interviewing, not being afraid to ask questions and discuss, or not shying away from the topics.
Awesome. I love hearing about the work that you're doing. And thank you again for sharing in the chat box some specific examples about what it looks like to promote cultural-based strengths. Next slide. So as we engage young people and families, we should also be intentional about respecting young people and families as the experts on the child's strengths and needs. And in doing so, be intentional in asking questions to learn from youth and families about what they do to be well. And then use this information to understand and encourage family coping and wellness. Related to your engaging families, it is so important that in the work that we do with all families, that we are intentional about exploring youth and family culture and identities. And do so by using questions that are very clear and specific. And some examples of questions that I pulled from a resource that is linked here on the slide that has a ton of questions that could be useful for clinicians who are talking with families about culture and identity, but may not know quite what questions to ask. Some examples are, if you had to describe your family using 3 words, what would they be? How would you describe who you are and where you are from to someone new? What are your top 3 goals or values for your child, family? What languages do you speak at home versus at school or in the community? Do you have specific religious or spiritual beliefs? And what are important things you do or believe related to religion and spirituality? Next slide. So it's also helpful that in our process of engaging youth and families, that we are asking questions to understand the beliefs, values, and needs of our patients, including health-related beliefs that are often impacted by cultures. Information gained from these questions can be used to aid clinicians to support with clinician understanding of patient health beliefs and practices. And they can also support the clinician in deciding on their approach to patient education, as well as this can be useful information to support us in our process of problem solving barriers related to treatment adherence. And there is another resource that is linked here that has a ton of questions related to engaging families in health-related beliefs, as well as general questions related to culture. So I have a few on the slide here. How do you or your family or your community members think the problem or the condition should be treated? Have you tried remedies like herbs or remedies from your homeland? Who in your family, community, or religious group can help you? Are there religious food prescriptions and restrictions that you might follow? Next slide. Youth and families from groups that are marginalized often experience significant barriers to accessing mental health services. So the next strategy that that is culturally responsive is to support families with overcoming barriers to access to behavioral health treatment. And on the slide are some specific tips and strategies to support families with overcoming barriers. The first is validating the young person and the family's feelings, especially when they are bringing up concerns or worries about stigma or being treated unethically by providers. And then informing families that mental health problems in childhood are common and that quality mental health support and services are quite helpful. And if families are naming historical and unethical practices as a barrier or a concern that they have related to engaging in treatment, it's important to educate families on the fact that harmful practices are banned among professional academies and agencies, and also informing families and young people that there are providers and organizations that are very intentional about using practices that are culturally responsive and affirming for diverse identities. And related to that, it can be helpful to encourage families to openly express their needs to providers and to ask providers questions about their training and their process of ensuring that their therapist or clinician is a good fit for them. And then also in our work to support families with overcoming barriers to access to treatment, it's so important that as we are referring families to providers, that we are referring to providers who we know or are known to the community as providing services that are culturally responsive. Next slide. I actually think that is a typo. So next slide. All right. So the final culturally responsive and anti-racist and equitable practice is becoming a champion for systems change. It's helpful to promote resiliency, as we've talked about here today, but in order to change the systems that make resiliency for people to thrive a need, but in order to change systems that make resiliency a need for families, it's important that we do the work to change those systems. Because as practitioners, we are in a position of relative power and privilege compared to many of the young people and families that we serve. And we can use our time or voices and positions to engage in systems change efforts to promote equity. And on the slide are some examples of how to work as a champion for systems level change, including serving on community-based social justice organizations and committees, reporting equity issues to your organization's administrators or leadership, spreading awareness about social injustice or social justice issues through professional and social networks to influence policy, as well as serving as a social justice advocate and champion in your community. Right. Next slide. That closes my talk for today. And on the slide are some selected resources and references.
Thank you so much, Dr. Reason. I'll go ahead and stop sharing this.
All right. I thank you all for participating today.
Thank you so much for your expertise here. And Chelsea will facilitate our question session here and read some that we've gotten in the chat. But if we have any other questions, we do have about 10 minutes left. If you'd like to ask Dr. Beeson any questions, go ahead and type those into the chat.
Yeah.
Thank you. Dr. Beeson, it looks like we have one question. Is there a way to determine if a provider is culturally responsive?
Oh, that's a really great question. So there are a number of assessment tools that measure cultural responsiveness that are available for free online. And I can definitely get a link for a couple of those so that they can be shared with the resources. That's a great question. And I would say another kind of strategy to make an assessment of cultural responsiveness is to look to your governing body's guidelines and kind of code of conduct. I know for the related to multicultural competence or cultural competence, I know that's the language that is used for the American Psychological Association. And typically they provide guidance on what it looks like to be culturally competent. And that could be a starting place for assessing cultural responsiveness. Great question.
I think we did have an earlier question. What would maybe for EMTs or someone that's on a rescue squad, what would you recommend for them to do? And I think this was specifically asked when you were having examples of sharing how to promote a welcoming environment. What might be some tips for someone that's an EMT?
Yeah, so that's a great question. I think sometimes when we encourage folks to have conversations with their patients or clients about culture and identity, it's kind of confusing about what you're actually attempting to do and what kind of questions can be helpful in engaging folks in conversations about identity. And that's why I really liked the couple of resources that that I use to pull the questions that a provider can ask as they are engaging a young person and a family in conversations about culture and identity. So I would suggest that the provider takes a look at those resources and kind of think about what would be helpful for them to know in a process of working with a client or a patient.
So I'm not seeing any other questions at this time. I think one question that I hear often is, how do you respond to a family or a patient when you have misstepped? Because we will make mistakes in this process. So I'm wondering if you could just reflect on how you can work with a family when you have made a misstep.
Yeah, that's a great question. And I think it's so relevant for all of us, even those of us who value equity. I just reflect on the fact that sometimes it can feel really easy, for lack of a better word, to misstep or microaggress against someone by using language that may be outdated and we may not be aware of, or making an assumption that, is informed by an implicit bias that we don't have an awareness of. And so I think if you're in a position where you are aware that you made a misstep, or said or did something that's not culturally responsive, or anti-racist, for instance, and you are aware of that because the client or patient told you that, I think definitely you want to validate and acknowledge, and thank them truly for sharing with you how they have been impacted by what you've done or said. Because oftentimes when people are microaggressed, we see people dropping out of services or, and then, obviously that ends the relationship, and it can end our ability to kind of do the work to reestablish rapport. So definitely holding yourself accountable for the misstep, and not attempting to kind of question a person about the validity of how they feel, ensuring that we are validating a person's emotions, and we are working with them with the goal of restoring the relationship, if that's possible. And I think that there's a possibility that folks would be, a client or a patient would be open to restoring the relationship, and that would be great. And there's also a possibility that they wouldn't. And so if they are open to that, asking them, engaging them in, what questions that around, like how they felt, how they were impacted, what they think needs to happen in order to make it better, and then doing your own individual work through continuing ed or supervision or peer support to ensure that you are, restoring that relationship and learning from that process. And obviously, or not so obviously, but if the patient or the client has been impacted to the point where they no longer want to work with you, I think it's important that we do all of those things that I just said, and also validate how they feel, even if their feelings is that they no longer want to engage, because that's their right.
Thanks, Dr. Beeson. We have a question. What is the clinical supervision intervention for the clinician who is resistant to these concepts? And what is the intervention for the supervisor? Oh, sorry, same question.
Yeah, so what is and I see someone saying $1 million question. Yeah, I think it is $1 million question. And I think part of the reason why the question is hard to answer is that I think it depends on the individual and their situation, and what specific concepts they are experiencing. I think it is helpful to, point folks to supervisees and supervisors to opportunities to learn more, whether it be through talks like this or book studies, individual work. So just providing people with actionable things that they can do in order to support them in their learning process. I'm rereading the question to make sure I'm answering it correctly or based on my own knowledge. What is the clinical intervention for supervisors who are resistant to these concepts? It's hard for me to think about, what to do in the situations when there's a supervisor who's resistant to these concepts. It's hard or difficult for me to think about because that's really concerning. It's emotionally difficult for me to think about that, but that happens. And obviously, as providers, we have a duty of doing no harm and to also ensure that our colleagues are not doing harm to trainees, research participants, patients. And so if we see someone who is in that, in our profession, or who has a code of ethics that, clearly states that they have a duty to do no harm, and we see them engaging in practices that are harmful, we have to do our due diligence to really respond to that problem. So having a conversation with the individual, reporting it to leadership and administrators, or even reporting it to that person's licensing board. But I think obviously the first step would be to, talk with the individual and see what can be done to support them with addressing their need. All right. Thank you, Rebecca, for adding the evaluation to the chat box, and thank you to all of the participants for participating in the training and sharing your reflections in the chat box.
Thank you so much for sharing your expertise with us today, Dr. Beeson. We really appreciate it. It's very valuable information, and it will be on our website later, and we'll send out the slides and related resources that Dr. Beeson talked about today as well.
Thank you, Dr. Beeson, and thank you everyone for joining. Take care.